Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. Everyone is touched by psychiatric conditions, either themselves or a loved one. Do not suffer in silence. With help, there is hope. Today on Healthy Minds,
we have a blueprint for this in psychiatry. We went through the struggle of these various underrepresented groups, challenging the organization that represents our profession to get it together and really begin to look at some specific things. And we keep missing the mark on that. I'm very optimistic about the future of psychiatry simply because I've been around the young people who will be that future, and they are not taking no for an answer. They are demanding that we who create these systems address these things. They're challenging us on a regular basis, and every now and then I have to remind them that you don't get this old not knowing a few things, so we're not completely clueless, but we are, I think, stuck in a tradition that has not allowed for change as society has changed.
that's today on Healthy Minds. This program is brought to you in part by the American Psychiatric Association Foundation, the John and Polly Sparks Foundation, and the New York State Office of Mental Health. Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. Often people who need help for psychiatric conditions have difficulty accessing the care that they may need. This is especially true for people who are minorities. Today I speak with leading expert Dr. Altha Stewart, who shares her experiences on this important issue. Altha, welcome. Thank you for joining us today.
Thank you for the invitation.
We know that conditions such as depression and anxiety and bipolar disorder and schizophrenia and chemical dependency really doesn't know ethnic and racial boundaries. It hits everybody.
Yeah.
But we also know that people who are a part of minority communities have a more difficult time, because everybody often has a difficult time, a more difficult time accessing treatment. And I'd like you to speak about that important issue.
It is the dilemma of our lifetime that we are still struggling generally with mental illness and stigma, but specifically in people of color. And in underrepresented groups and underserved groups generally. I'm most familiar with the Black community because that's my community. And so I do a lot of work in the education around the mental health needs of Black people, the rising suicide rate among Black youth. And I'm really impressed with the number of young millennial age Blacks, celebrities, athletes, entertainers, actresses and others who are coming forward now to talk about their issues in the mental health arena. The number of suicides in the Black community is rising. There was a time in my lifetime when people said Black people didn't commit suicide. We know that's not true, and we've had some very high-profile suicides of late. So I think it's the education and information sharing, it's the storytelling. When people hear that someone with that level of celebrity suffers, it normalizes the fact that
Makes people more comfortable to talk about
maybe
it.
I can talk about it too.
And get help too.
Yeah. So we're hoping in my community, we're hoping that as more people talk about it, who have some clout and presence in the community, it'll be easier for other people to admit that they have problems. Now, then the problem is going to be access, because when you decide you have a problem, then you want to see someone. And for many people in most minority communities, they want to see someone who looks like them, and there simply aren't enough of us. We don't have enough in the pipeline. I think at last count, maybe 4% of all psychiatrists were Black psychiatrists. And the number of people that we'd like to help get some treatment far exceeds our ability, our capacity to serve them, which takes us through the cultural competence, cultural competency, cultural sensitivity, cultural humility, all of those cultural aspects. You know, fortunately we have the DSM and the cultural formulation, but it's going to take a little more, I think, to really make this kind of treatment available in a way that is culturally sensitive and responsive. Everything from how people ask for help, to how they respond to help, to how they benefit or sense that they're benefiting from the help. All of those things have to be taken into account. And I don't know that our training programs are ready yet to put all of that in place so that whoever's seeing this patient has a sense of what is going on in their world and can address it from where they are.
I want to ask you how you became a psychiatrist. What brought you into our field?
That's actually a very good story. It's a two-part story. In med school, I thought I was going to be a pediatrician or a pathologist. And you know, the first clinical rotation, when you start your clinical rotations, is in the summer, that July period. And I chose to start my clinical rotations in psychiatry. I don't know why, how it got scheduled or anything, but it turned out that I was the only student on the service. And so I got the full attention of everyone. I had the status of junior intern. I had my own service where I followed certain patients. I got to present to the godfather of psychiatry in the Philadelphia area where I trained. And it gave me a real good sense of psychiatry, the specialty. And even though people said, well, don't get too attached because you can be a real doctor and those kinds of things, I really did fall in love with psychiatry. And I was a little bit put off because I planned to be a pediatrician or a pathologist. But I went through all the other rotations and they were okay, but I kept thinking about psychiatry and ultimately decided that I would go into psychiatry. And trained in Philadelphia as a community psychiatrist and really have had a very full career professionally. But before medical school is the other part of the story. I was in a pre-med biology program at my college in Memphis where I was born and raised. So before med school, I had this summer opportunity where a bunch of us minority students who were interested in medicine got to go spend the summer at Harvard taking pre-med courses, basically, histology and anatomy and some biochemistry. And a part of the program was mock interviews for med school. I was interviewed by Dr. Alvin Poussaint, who was the only black psychiatrist I'd ever heard of. He wrote in Ebony and Jet, which were in every black household I ever knew. And I remember sitting in the interview and having him say to me, you know, you've got the smarts and everything, but I just don't sense that you have the interest in medicine. Are you sure you want to be in medical school? And I said, of course I want to be in medical school. Absolutely I want to be in medical school. And he said, well, I'm not getting the feeling that you want to be in med school, so maybe you ought to step aside and let someone who really wants to do it come to medical school. And I was crushed. Not only was I being told that I wasn't able to do it because I didn't have the passion, I was being told this by Alvin Poussaint, who I subsequently was able to show that I had not taken his advice and had gone on to medical school and furthermore had become a psychiatrist. And I had the occasion to introduce him once and he'd forgotten all about it, of course. It stuck with me as a critical point in my development professionally. And I told the story when I introduced him and he kind of chuckled and said, well, you know, I don't recall the incident, but it sounds like something that I would say. And it is such a mark of, you know, accomplishment that I went from him telling me I didn't have the passion to presenting him this year with a Distinguished Service Award at the American Psychiatric Association meeting.
While you were serving as the president
Yes.
of the American Psychiatric
Yes.
Association.
Yes,
So,
this girl who had no passion for medicine went on to become a psychiatrist and president.
and the leader in the field.
Yeah, in the field, and he's gotten a chuckle. We've become good friends over the years, and he gets a chuckle out of it every time I tell that story. But that really was the beginning, and then my experience in med school where I felt this overwhelming relationship with psychiatry. that really sealed the deal for me. And I just stopped listening to the people who said, well, you can be a real doctor, why would you be a psychiatrist? Or psychiatry's not really medicine and you're never gonna. I just stopped listening to them and went on and decided to have a great career in psychiatry.
And you have.
Yeah, I have.
One of the areas of impact that you've had as an African American woman is leadership with regards to diversity and with regards to access to treatment for minorities, in particular African Americans, but really all minorities. And I'd like you to share what it's been like for you as an African American woman to do that.
Well, it's been sort of a combination of things. I've had some absolutely tremendous and positive experiences, and I've had some very heartbreaking experiences in this path into the leadership role, ultimately into the APA presidency, because of the lack of real understanding of diversity and inclusion in the profession. We talk a lot about cultural competence when it comes to treating patients, but we have psychiatrists from a variety of racial, ethnic, sexual orientation, and gender specific groups that are struggling to feel that they are a part of this profession, either because of the way they're treated, because of the way they aren't allowed to grow and develop in the same way that their white male colleagues primarily are. And as a profession, I've been somewhat disappointed by the fact that we still don't seem to get it. I mentioned in my presidential address a couple of months ago that we have a blueprint for this in psychiatry. We went through the struggle of these various underrepresented groups challenging the organization that represents our profession to get it together and really begin to look at some specific things. And we keep missing the mark on that. And I'm hoping that this group of young people who are, they're marked by this passion for social justice. They understand the importance of health equity. They really want to see a real paradigm shift in how services are designed, how they're offered, how people access them, and how they are somewhat customized in some respects to meet the actual needs of the people receiving them. They don't believe in the cookie cutter model of everybody gets this and everybody gets that. They really do want to see their life experience, and they are by and large challenging us older psychiatrists to wake up and see the world around us changing and really begin to look for ways to make our field relevant to this changing world.
In some ways, the challenges that some psychiatrists have experienced in the field because of prejudice and because of issues around diversity, those issues parallel society and what people in any profession may feel, and certainly what people who come to us seeking help because of depression or anxiety or some other condition may be experiencing. So being sensitive to that is extremely important.
Extremely important. You know, as you know, the APA has a large physician wellness and burnout initiative. And we've done 2 or 3 years worth of work looking at our profession, what kinds of factors specific to psychiatry may be at play. And one of the early results was that we weren't getting a lot of feedback, positive or otherwise, from our minority members, from our female members, from our members who may have trained as international medical graduates, that they were not responding to the surveys and the interviews and the other stuff that was going on, such that our data was skewed. We knew a lot about a certain cluster of psychiatrists, members and non-members, but we knew very little about what's causing burnout. Burnout is a big issue in the medical field today. And we've got lots of information about electronic health records, about the requirements and the limitations of the new reimbursements, and how it is hard to practice with all of these for-profit companies owning healthcare. But we know very little about what's going on in these other communities of physicians, of psychiatrists, that is creating burnout and wellness problems for them. And so we've now had to drill down a little deeper to specifically look to them for some of that information so that we can design wellness programs that specifically address their concerns. As I have traveled around the country as president of the APA last year, by far, the biggest reason that people cited to me for their sense of burnout was how they were being treated in their work setting, based on race, ethnicity, gender, sexual orientation, the kinds of things that were being said to them or about them, the opportunities they were not getting that they saw their counterparts who were often not as qualified getting. And in a few cases, a behavior on the part of a patient or a colleague that if it were physical, we had protocols for handling. These verbal assaults on faculty, on trainees around their race, their gender, their ethnicity, their religious persuasion, all of that, people were complaining and no one was doing anything about it. And that was resulting in them feeling less inclined to want to be in the field, less likely to stay in the field, and more angry about the things that weren't happening and feeling more burned out.
I want to ask you about the effect of prejudice that exists in our society for minorities of a variety of different types of minorities, and how that affects people's mental health.
You know, I'm friends with Alvin Poussaint, who launched a campaign about 30 years ago looking at racism as a mental illness. And it was challenged by every psychiatrist, or just about every psychiatrist in the country, because it was considered, if we say racism is a mental illness, then we're letting people off the hook for these bad behaviors. Alvin's point was, we need to acknowledge that people who express racist ideas, who behave in racist ways, are having delusions of something that does not exist. They're projecting onto people that are not like them behaviors, things, activities that literally are not real. We call that in our profession delusion.
A fixed false
belief. Yes. There is a defined way of looking at these things, yet in society, it is very difficult to get people to own up to the fact that we are not addressing the root cause of many of the things that bring these particular patients, Black, Hispanic, Asian, Native American, gay, lesbian, bisexual, women, people for whom English is not their first language. We're not looking deep enough into what the environment that they are living, working, or just being in existence in is doing to their psychological health and well-being. And we're literally dismissing the fact that it has any impact. We learned the lesson of trauma having an impact, but we seem to be reluctant to tackle the racism, discrimination issues and how they impact one's psychological health and well-being. We're making more headway in environmental and climate change issues and the impact on mental health than we are with race and ethnicity and mental health.
That the effect of experiencing prejudice on an ongoing basis really can have an effect. The effect is on people's mental wellness.
If you tell a person long enough that they are unworthy, they don't matter, they aren't a contributor to society because all they do is take, if you set up a system, a structural system, where they can't buy a decent house, get a decent job, get a good education, raise their family, or do any of the things that we all want to do, if you do that long enough, and I mean long enough like for generations, you leave them with no hope. And we know that people with no hope are at risk for a lot of things happening, not the least of which is developing a mental illness. These are the foundational roots of depression, the host of anxiety disorders, the antisocial behaviors that result in all kinds of other things happening. And as a society, we have put our resources into sustaining a system that devastates people and has been for generations. As a profession, I think we have a responsibility as psychiatrists, because this is our wheelhouse. How people psychologically manage the things that happen that place them at risk for serious problems.
We know that stress
Yes.
of any type, but stress is a risk factor for developing depression, anxiety,
Yes.
other conditions. So being aware of stress that racism and discrimination can cause for people who are minorities is extremely important for us, first to acknowledge that and then to begin to address it.
Exactly, and if we're going to train the next generation of psychiatrists to handle those things in the therapeutic setting, then we, the trainers, we, the supervisors, we, the faculty, we, the chairs of departments and directors of residency training, have got to figure out how we translate that awareness into a shared understanding and educational format so that they go out armed with the necessary skill to handle these things. I don't want people getting their therapy online. I don't want them typing in, I feel this way, and some algorithm out there shooting back a response.
We want a human being.
Yeah, I want somebody who looks them in the eye, who watches their body language, who hears their voice and matches it with their demeanor and says, you know, something doesn't match up there. Let's talk about that.
What can we do to help?
Yeah. That's the psychiatry I'd like to see in the future. It continues to be grounded in the interpersonal therapeutic interaction, but it has as an asset all of these bells and whistles that these young people know how to do with their apps and their, texting and all of that stuff.
As an adjunct.
As an
to
adjunct,
treatment.
yes. I think I'm very optimistic about the future of psychiatry simply because I've been around the young people who will be that future, and they are not taking no for an answer. They are demanding that we who create these systems address these things. They're challenging us on a regular basis, and every now and then I have to remind them that you don't get this old not knowing a few things, so we're not completely clueless. But we are, I think, stuck in a tradition that has not allowed for change as society has changed.
To somebody watching right now, they can be African American, they can be any ethnic group, and they're suffering. What do you say to them?
Get help. And if you can't find somebody that you think is a good fit because they look like you, get help from somebody where when you go in and say, I think this is a part of what's bothering me and I'd like to talk about it. Are you comfortable with that? When I came through training, we were taught in the old psychodynamic psychotherapy model that you met the patient where they were and you did certain things. We weren't into disclosure about ourselves and our circumstances. In today's environment, given the impact of social media and how often people go online to look for their therapy online, it's changed the way I think that we're going to have to work with people when they come with a set of ideas. And I would encourage anyone, no matter what their race and ethnicity, to get help first and foremost. But if they're really struggling with something that they believe has to do specifically with their identity, race, ethnicity, gender, sexual orientation, having the courage to bring that up and finding a therapist who will work with you in that space also, I think is pretty good.
It's important to find a person that is the right match for your life. Because it's not just symptoms, it's not just the diagnosis, but it really is the circumstances of your own life.
But the person out there has to be willing to say, I need to talk about this now.
So if it's on your mind,
Bring
if
it
it's
up.
in your heart, bring it up.
Bring it up, yeah.
Well, I think that your leadership has had an ongoing impact, and I want to thank you for all that you've done and all that you continue to do. And thank you for joining me here today.
Thank you so much. I've enjoyed it.
Thanks. If you're experiencing depression, anxiety, other psychiatric symptoms, don't suffer in silence. Seek treatment. Find a psychiatrist or other professional who is a good match for you, who can help you. With help, there is hope. Do not suffer in silence. With help, there is hope. This program is brought to you in part by the American Psychiatric Association Foundation, the John and Polly Sparks Foundation, and the New York State Office of Mental Health. Remember, with help, there is hope. Until next time, I'm Dr. Jeff Borenstein.